So thank you very much. My name is Dermot Smith, and thank you to the RCSI for asking me to speak today. So I'm going to talk a little bit about type 1 diabetes. Next slide, please. So last year was the 100th-year anniversary of the discovery of insulin. And before the discovery of insulin, if you had type 1 diabetes, essentially you died. Patients with type 1 diabetes would have died within a year to two of diagnosis from ketoacidosis. And the gentleman on the right was actually a surgeon, Frederick Banting. And he's pictured on the left here with Charles Best, who was a medical student at the time. And Banting actually ligated the common bile duct, and you removed an extract from the common bile duct, which suppressed ketosis, inhibited lipolysis, and was involved in the metabolism of carbohydrates. And he called it inulin at the time. And essentially, the dog in the front is a dog called Marjorie, and Banting removed the pancreas from Marjorie and injected his extract into Marjorie and kept her alive for 70 days. And essentially, when he stopped the extract, Marjorie died. And that was the first discovery of insulin, and it was a miracle at the time. So I think it's really noticeable, and I'm sure Banting would be delighted that we have a surgical group here trying to learn a bit more about diabetes. So I think that's a fantastic initiative from the RCSI. Next slide, please. So type 1 diabetes is common, and it's a genetic condition. So patients with type 1 diabetes are born with a genetic predisposition to developing type 1 diabetes. And then something happens, probably a viral trigger that triggers an autoimmune response, and those antibodies attack the beta cell of the pancreas and destroy the beta cell of the pancreas. So type 1 diabetes affects about 23,000 adults in Ireland. And essentially the key point here is that these patients are not producing insulin. They're insulin deficient. So their treatment is either subcutaneous insulin injections or a subcutaneous insulin pump. There's no role for oral hypoglycemic agents per se in the management of these patients. And the key point is that if you don't give them insulin, and if you hold insulin or withhold insulin from them, they're at risk of developing ketoacidosis. Ketoacidosis is a medical emergency and is associated with death. 1% of patients with diabetic ketoacidosis can die. Next slide, please. So we define diabetic ketoacidosis as a glucose level of greater than 11.1 millimoles with blood ketones of greater than 3 and a pH of less than 7.3. And this is our protocol in Beaumont Hospital of how we manage it. Now, I don't expect you to remember this. This is a medical issue. And obviously, if someone develops ketoacidosis, you'd ask for a medical consult. But there's just a couple of key points. One, ketoacidosis can often present with abdominal pain. So if a patient with type 1 diabetes or type 2 diabetes, because 5% of type 2 patients can develop ketoacidosis, come into casualty with abdominal pain, this could be ketoacidosis and a medical issue. Secondly, if you're on the wards with somebody with type 1 diabetes and they're sick, it is always very useful to measure their blood ketones. Next slide, please. Now, when we have a patient with type 1 diabetes, they're deficient in insulin, as I mentioned. And so what we try and do is mimic what the normal beta cell of the pancreas does. And the beta cell of the pancreas produces a little bit of insulin every minute of the day. And that is called basal insulin. So essentially, if a patient with type 1 diabetes decides to wake up tomorrow and says to himself, I'm not going to eat anything today, they're still producing a little bit of basal background insulin. And that basal insulin sort of suppresses hepatic gluconeogenesis, inhibits lipolysis, and keeps the patient out of trouble. So that basal insulin is extremely important. Then when the patient eats a meal with carbohydrate, then they get a spike in their blood sugar and they get a spike in insulin production in the non-diabetic to match that meal. And we call that bolus insulin secretion. So we have different insulins that are basal insulins and different insulins that are bolus insulins. Next slide, please. So this is a list of names of the basal insulins that are available in Ireland. Now, the older basal insulin is called NPH or Insultard, which is a cloudy insulin given once or twice a day, typically used in pregnancy. The other basal insulins listed are more commonly used. They're clear insulins, and they're given once or twice a day. Now, if they're given once a day, that can be given at any time of the day, either before breakfast, lunch, evening meal, or at bedtime. They're usually given in the evening or bedtime. The Levemir insulin is often given twice a day. Next slide, please. Those basal insulins that I showed before typically last for 24 hours. So when you inject them, they last for up to 24 hours. The bolus insulins are listed as here. Now, the oldest bolus insulin that we have is called Actrapid or regular or soluble insulin. Now, that's an insulin that you inject about 30 minutes before you eat. It peaks after 2 hours of injection and hangs around for about 5 to 8 hours. The other insulins, the NovoRapid Humalog Glulisine, we recommend that they're injected maybe about 15 to 20 minutes before you eat. They peak within about an hour of injection and they last for 4 to 5 hours. And now there's a newer, quicker acting insulin called Fiasp insulin that you inject as you eat. And again, that lasts for about 4 to 5 hours. It gets absorbed a bit more quickly than the NovoRapid insulins. So these bolus insulins are given with meals. Now, we also have pumps, and about 10 to 15% of type 1s are on insulin pump therapy. And this is one of our newer pumps on the right-hand side. Clips onto the belt or sits in a pocket, and there's an infusion kit coming out of it that delivers subcutaneous insulin. So a little needle is inserted subcutaneously, the needle then removed, and you have an infusion site that delivers subcutaneous insulin. Now, the pump delivers the bolus insulin. So when a patient's on a pump, the bolus insulin becomes both the background and the bolus insulin. So the pump delivers a little bit of insulin every couple of minutes, such as NovoRapid. And then when the patient eats a meal, they press a couple of buttons on the pump to deliver the bolus of insulin. So that's an important point to remember. If you have somebody on a pump and the pump blocks or dislodges or gets removed, because there's no longer acting basal insulin on board, the patient can very quickly go into ketoacidosis. So that's a very important point. On the left-hand side, you see this CGM device that Sean has mentioned, which is a continuous glucose monitor. And that can send a signal to the pump or to a phone device that the patient may have, and it can give a real-time glucose reading. Now, these systems are very elaborate, and these CGM devices can detect if the blood glucose levels are starting to go low and can tell the pump to stop delivering insulin before the patient goes hypoglycemic. And when the glucose levels then start to rise, the sensor will tell the pump to re-deliver the insulin. Now, an important point with these sensors, which are becoming increasingly common, they use an electrical current in the sensor. So if a patient is going for surgery, you can't use diathermy with the sensor. You need to remove the sensor. If you remove the sensor, the pump will still work, but the sensor would need to be removed, and it also needs to be removed if you're going for an MRI scan, etc. Next slide, please. So these sensors can also be used with multiple daily injections. They don't necessarily need to be used with a pump. This is a continuous glucose monitor that relates to a phone called the Dexcom system. And this Dexcom system can get your phone to alarm if your glucose levels are going too low or too high. They're very useful, and we've seen significant improvements in diabetes control with this technology. This is an intermittent sensor or a Freestyle Libre system. It's intermittent because you just need to activate the sensor with your phone or a handheld device to see the reading. But this technology is becoming increasingly prevalent, and the ADA and the European Diabetes Associations both recommend that they should be offered to all patients with type 1 diabetes. So you'll see patients coming into the hospitals with this technology. Next slide, please. So I'm going to give you some cases about how to manage type 1 diabetes on the surgical wards. And I'm going to show you some of the protocols we use in Beaumont, and most hospitals have their own protocols. But this is a 31-year-old female with 10 years of type 1 diabetes. She's on Lantus 24 units a day. Lantus is her basal background insulin. She's on NovoRapid pre-meals and she carbohydrate counts. So that means she's adjusting her NovoRapid to carbohydrate. So instead of being on fixed doses of, let's say, NovoRapid 6 units before each meal, we encourage our patients to carbohydrate count. And that, so a patient might end up on 1 unit to 10 grams of carbohydrate. And if they come into hospital on carbohydrate counting, we'd encourage them to continue to use that scale when they're an inpatient in hospital. She's got reasonable diabetes control with a HbA1c of 7.8%. Ideally, we aim for a target of less than 7%. And she comes in for an elective hernia repair, and her blood glucose is 7.8 on admission. Next slide, please. So this is the protocol we use for our patients with type 1 diabetes. So essentially, the day before their surgery, we give them their usual dose of their basal insulin the night or the day before the operation. The day before the surgery, they're eating properly, so they take their bolus insulin with meals. They fast from midnight. If they go hypoglycemic overnight, they can take some dextrose sweets to bring their glucose level back up to normal, and that doesn't stop them having a general anesthetic. On the day of the surgery, if they take their basal insulin in the morning time, we reduce the dose by 20%. Because they're fasting, they're not eating, so they don't take a bolus insulin dose in the morning time. So they don't take their quick-acting NovoRapid, etc. If they come in with glucose, we then recommend starting them on an intravenous insulin infusion. If they go low during the operation, you treat the hypoglycemia appropriately. And then once the operation is over and they're allowed to eat again, then they take their bolus insulin with the food. And then if they're on their basal insulin at nighttime, they take their basal insulin at night. So this protocol is getting away from the glucose potassium insulin infusion that may have been used in the past in a number of hospitals. In the moment, we don't necessarily use that anymore. The day after surgery, if they're eating well, they take their usual doses of insulin. Next slide, please. Now, if they come in on an insulin pump is a very effective way to manage diabetes around the time of surgery. So we'd actually recommend that they wear their pump during the operation, and that can manage their diabetes control appropriately. However, again, if they come in on the pump and their glucose levels are high, they take a correction bolus through the pump, and the patient should be educated on being able to do that. So they might take a bolus of quick-acting insulin to lower the glucose levels. That should bring the glucose levels down within a couple of hours. But if it doesn't, then we'd recommend stopping the pump, switching the patient to an intravenous insulin infusion, and I'll explain that in a slide or two. Store the pump safely for the patient, and then when the patient's well after surgery, they can restart their pump therapy. Next slide, please. So the same case comes in for a hernia repair, but our glucose level is 22. The first thing you do in this setting for blood ketones. Next slide, sorry. And if our ketone is positive, then you'd be worried that the person has diabetic ketoacidosis. So if our ketones are positive, then she could have diabetic ketoacidosis, particularly if the blood ketones are greater than 1.0 millimoles, and we ketones, you'd cancel the surgery, consult endocrinology, medical emergency, IV fluids, IV insulin infusion. If our ketones are negative, the surgery could still go ahead on an intravenous insulin infusion. Next slide, please. Variable rate insulin infusion, and this is the protocol we use, where we get 50 mils of Actrapid with 50 mils of normal saline. We put it in a syringe driver and we infuse it intravenously. We typically start off with 6 units per hour. We check the glucose every 1 to 2 hours. We pump the glucose level down using this scale. Essentially, when the glucose level gets to less than 10 millimoles per liter, we add in a bag of 5% dextrose, at about 100 mils per hour to maintain normal glycemia, because if you leave them on the IV insulin, dextrose are likely to go hypoglycemic. The IV insulin then stopped, risk of ketosis can arise. So we use the IV infusion initially on its own to pump the glucose down, then start some dextrose to maintain normal glycemia and bring the patient through their operation. Next slide, please. Another case of a 68-year-old man who comes in, type 1 diabetes. He's on the standard basal bolus regime of the Lantus, which is the basal insulin once a day, and the bolus insulin with meals. But he's got a ruptured aortic aneurysm. So he's in the middle of the night, emergency surgery, glucose level is high. Next slide, please. Again, if glucose level is high, check for ketones. Ketones positive, then he needs to be treated as a DKA. If his ketones are negative, but he's emergency surgery, then we would go for the variable rate insulin infusion. We'd start them on that intravenous insulin infusion. We would leave them on their basal insulin. We'd continue to prescribe their basal insulin because that makes it easier for us to transition them off the IV insulin back to subcutaneous insulin in the future. If they were on a pump, we'd stop the pump, leave them on their intravenous insulin, and store the pump safely for the patient so that he can restart it when he's well. Next slide, please. Another case, and this is probably one of the commonest cases you'll see. So this is a 36-year-old female with type 1 diabetes for 12 years. Now she's on NovoRapid, her bolus insulin, 1 unit to 10 grams, and she's on a twice daily basal insulin, 12 units in the morning and 14 units in the evening of Levemir. She's had a laparoscopic cholecystectomy, and on day 3, she started to vomit and not eating, and her glucose level is 4.2, and the ward nurse says, should we hold the insulin? And this is really one of the key points of this lecture tonight. In type 1 diabetes, you don't hold, you do not stop the basal insulin treatment. So in this case, if the ward nurse asks you, should we hold the insulin, you continue to give the basal insulin. Now, you may need to reduce the dose maybe slightly by a couple of units because the glucose level is 4.2 or if she was hypoglycemic, but you continue to give the basal insulin. So you never, ever, ever, ever stop the basal insulin. Next slide, please. Because she's not eating pre-meal NovoRapid, her glucose level is only 4. So you could hold the pre-meal NovoRapid. We would recommend using supplements of NovoRapid, and I'll explain that in a second. You need to monitor the gluconders carefully. Levels start to rise. Consider checking for send the consult to endocrinology. Next slide, please. So this is what we use now instead of really the traditional sliding scale. To me, when I'm trainee, we used to use a lot of the 2-hour sliding scales using ActRapid. Now, remember, ActRapid took. So in the old days, we used to have a scale where maybe a patient with diabetes, their glucose level was 18, and they'd be charged for 6 units of ActRapid. And then 2 hours later, the glucose level would be 18 because the ActRapid hasn't kicked in. The nurse would give another 6 units of ActRapid. Then 2 hours later, the patient would be hypoglycemic because they've now had 12. So they become hypoglycemic. They're then given rescue therapy to treat the hypoglycemia. The glucose jumps back up to 18. They're given another 6 units of ActRapid. 2 hours after that, it's still 18, given another 6 units of ActRapid. So the 2-hour sliding scale ActRapid should not be used. It's bad. It's bad practice. Instead, we use these supplementary scales. So essentially, this is trying to take the edge off hyperglycemia for a patient. We recommend that you chart their usual bolus insulin. So if they're on NovoRapid, you use NovoRapid. It's given at pre-time to let the insulin take a little bit of time to work. And we write up a scale like this. We're aiming for glucose levels moles. but we could live with 4 to 12 millimoles. So with this supplementary scale, they take their usual dose of bolus insulin, and if they're high, then they take an extra dose of NovoRapid with. Again, if somebody is not eating, let's say you're not giving them their usual bolus NovoRapid, but their glucose level was 12.4, you'd give them 2 units of NovoRapid. NovoRapid to correct a glucose level that's slightly high. Next slide, please. So again, with this case, and this just illustrates it a bit more, again, the same patient on laparoscopic cholecystectomy starts vomiting, glucose level of 16. The ward nurse asks you, should we give the insulin? So again, next slide. Again, your approach would be to check for ketones. If positive, you treat them as a DKA. You give the basal insulin. You then can go to your supplementary scale and give a correction dose to try and lower that glucose level. If the ketones are initially negative, but then start to rise, then you're in trouble and you need to intravenous insulin and ask for a consult to endocrinology. Next slide, please. There's some special circumstances for type 1 diabetes, and if patients are on TPN with type 1 diabetes, I'd recommend an intravenous insulin infusion. That's often the best way to manage them. If they're on NG feeding, in Beaumont, we certainly recommend the use of BD, basal insulin, and often we use regular bolus insulins to match and to accommodate the 2 or 4 hours that they're broken off the NG feed. Steroids will of course increase blood glucose levels, so standard insulin doses need to be increased across the board by maybe 20 to 30%. And BD mixed insulin is a bit of a challenge, but I'll leave that to Dr. Bogdanay, who's going to talk about that in her presentation. Next slide, please. So this is an important slide, and I actually saw this week on one of our urology wards. And essentially, this patient was on 8 units of Lantus. But the team, or one of the NCHDs, looked at the chart and looked at an old outpatient note where the patient was prescribed 8U. So the doctor had written in the clinical letter 8U Lantus BD. Now the doctor then transcribed that 8U as 80 and wrote milligrams instead of units. So the patient got 10 times their Lantus dose and spent the whole night hypoglycemic on intravenous dextrose to try and keep his glucose levels in normal. Next slide, please. So a key point is insulin is a high-risk drug. And when you're prescribing insulin, you need to be careful about the prescription. Never prescribe U or IU. If you're prescribing insulin, you have to write units. Next slide, please. I'll finish up there just by sort of saying again to emphasize type 1 diabetes patients are insulin deficient. Don't stop the basal insulin. Be careful when you're prescribing insulin. It's a high-risk drug. Use your hospital guidelines and always ask your helpful endocrinologist for assistance if you run into problems. Thank you very much.